Good afternoon, everyone, and welcome to the Lynn Cancer Institute, our series of keeping you in the know in 2024. We're very grateful to have all of you with us today to learn from our very own physicians who will educate us on the newest information on colorectal cancers. In our physician panel presentations, we like to educate you on early detection and screening, diagnosis and treatment options, as well as prevention. Unfortunately, yesterday, we received a notice that Dr. Jordan Mosisan will be unable to join us today due to a family situation. So we're especially grateful to both Dr. Saeed and Dr. Grabulski for covering some of the information that Dr. Mosisan would have covered. Since Dr. Mosisan is a colorectal surgeon, we will not be able to address treatment options from a surgical perspective. But if any of you have questions, I will be sure to get the information to you. At the Lynn Cancer Institute, we believe that education, along with the expertise of our staff and our latest technology, will truly save lives. In the interest of time, Lee has sent their bios for our physician speakers to you by email. Your Zoom will be muted during their presentation, so I invite you to take notes and put your questions in the Q&A or the chat box, and the speakers will be able to address those after their talks. Dr. Saeed will have to leave after her presentation, so we'll take a few minutes to do a Q&A to see if there's any questions prior to Dr. Grabulski speaking. We're very proud to welcome you to the Lynn Cancer Institute and to introduce Dr. Hina Saeed, radiation oncologist at the Lynn Cancer Institute. Dr. Saeed.
Hi, everybody. Thank you so much for allowing me the opportunity to present today. Thank you to all the attendees who have joined to hear this talk about rectal cancer. Unfortunately, as we already alluded to, Dr. Mosison will not be with us, but I will try to handle a few of the things that I think might be relevant from a surgical standpoint. All right, let's proceed forward. And not everything on the slide is for you to absolutely have an understanding, but it might be a good idea to just go through some finer points. So I really have no disclosures, not even AI was used for this PowerPoint presentation. Okay, colorectal cancer is really the third most common cancer in the US. Estimated incidence of rectal cancer in 2022 was roughly approaching 45K. So roughly 27K in males, 18K in females. It tends to be a little bit of a higher incidence in males and African Americans. Overall incidence of rectal cancer, however, is declining, but the incidence is rising in younger patients, typically under the age of 50. Just to give you a ballpark idea, there's been a 2.1% per year increase from 1992 to 2012. And primarily, these are left-sided colon cancers and rectal cancers. Again, third most common cancer, you can see where it's lying on the table here in both the males and the females. The second most common cancer is lung for both males and females. And again, for males, it's prostate as the most common and breast is the most common one for female. All right, so what are the risk factors and protective factors when it comes to colorectal cancer? So advanced age, typically as all of us age, we tend to have a high propensity to develop cancer. Male gender is associated with it too. Having a risk of inflammatory bowel disease, especially ulcerative colitis, is an associated risk factor. Diet, especially high fat, low fiber, low folate, red meat, alcohol, tobacco use, having a history of diabetes, cholecystectomy, somebody took out your gallbladder. Those are all risk factors. The family history and genetic syndromes such as HNPCC and FAP, typically these syndromes do give you a much higher probability of developing colorectal cancer, upwards of 70%. Some other potential protective factors would be fiber, having vitamin B6, vitamin D, NSAIDs, and aspirin. HNPCC, and there's a typo there. The Lynch syndrome, microsatellite, is usually caused by a microsatellite instability. No need to go into the specific part of it, but really is a mutation in one of the repair genes. So these tumors can be synchronous or metachronous. The risk of developing colorectal cancer is at a young age compared to the general population if you tend to have this Lynch syndrome. And then there's an increased risk of other malignancies as well. So when one of us gets diagnosed with Lynch syndrome, supposedly the primary care physician or the general practitioner is keeping an eye on all of these other screenings as well. Then there's another genetic syndrome goes by the name of FAP, familial adenomatous polyposis, which is due to an autosomal dominant germline mutation in one of the genes. And again, the risk of developing colorectal cancer occurs at a younger age compared to the general population. Tumors generally do not arise from an adenoma, which is usually the most common way some of these tumors can get diagnosed. Just when a patient goes for a colonoscopy, they take out an adenoma, and lo and behold, it turned out to be cancer. So again, there are some genetic variants that we do not need to go into. So this is important to know. And again, this is something that I would really like to know as a radiation oncologist and coming from a surgical standpoint as well, that where exactly is the rectum? What are we talking about when we talk about the upper rectum, the mid rectum, the lower rectum? So typically, rectum starts from the anal verge up to the rectosigmoid junction. It's approximately 11 to 12 centimeters in length. Some of the earlier studies have included up to 16 centimeters. So generally, we try to go into a ballpark of 11 to 15 centimeters in length. What is an anal rectal ring? Another picture in the next slide would show you where exactly that is. What are the layers of the rectum? If anyone has rectal cancer and they're able to look up their biopsies, they can hear all of these terms invading into the mucosa, muscularis mucosa, submucosa, muscularis propria, serosa, fat. So what exactly is mesorectum? That's important to know as well. And there's another picture that I can show you later on that will describe this better. It's really a loose connective tissue. It's not really a mesentery, which is another layer of tissue around the intestines up high in the abdomen. It's just loose connective tissue that is thicker posteriorly, and it contains a very important perirectal lymph nodes that often harbor the disease from the tumor. What is anal rectal ring? It basically comprises of some sphincter muscles and levator ani muscles, and that controls the anal incontinence. Yeah. So here's the anatomy that I was talking to you about. And I think pictures speak a thousand words here. So as this is the colon here, this is part of the upper rectum, 5 centimeters, 5 centimeters of middle rectum, another 5 centimeters of lower rectum. Right at this line, essentially, we have what we call the anal rectal ring and dentate line and the anal verge. So the anal canal at this anal rectal line is the area where anus meets the rectum. The dentate line is basically dividing the anal canal into the upper 2/3 and the lower 1/3. And then the anal canal extends outside via this anal wart. As we go down into the pelvis, that is more distal tumors, the risk of local recurrence increases. And surgery may entail, any surgery in that area, in the distal area, may entail a permanent colostomy, which we would like to avoid. And radiotherapy may be more important in those areas. And that's to spare the sphincter for continence. All right, so again, this is again beautiful picture of showing where the upper high rectum is, where the mid rectum is, where the low rectum is. Typically, on a practical basis, we oftentimes see tumors overlapping these multiple areas. All right, this basically talks about the same thing that we said, that the most important thing to understand is that any lesions proximal to this line right here would be part of the colon cancer and treated differently from rectal cancers. Okay, so kind of a little bit going into the weeds here, but it's important to know where the disease is and where it would like to travel. And that's exactly where the radiation oncologist work starts happening, because we want to know where the disease is, because we know where it likes to go based on the location of the disease, based on the size of the disease, based on the grade of the disease. So anywhere in the superior half of the rectum, it really likes to go to the portal system and to the liver. Inferior half of the rectum likes to go to the liver. And again, inferior half of the rectum, where it's extending into the anal canal, it likes to go into the lung. And then again, if it invades into the pelvic organs, such as the prostate, the bladder, the vagina, it again likes to go into the lung. Liver is the most common site for rectal and colon cancers, and lung is a more common site with rectal than colon cancer. From the pathology perspective, when somebody takes a biopsy of the tumor, what do the pathologists typically see under the microscope is what kind of tumor cells are there. And there's always going to be a robust discussion about what kind of cells are there at our multidisciplinary tumor board at LCI to define the further steps in management. So usually what we find in the vast majority of the cases are adenocarcinomas. 1 to 2% of these tend to have what we call signet ring features, which tend to portend a worse prognosis. Then there are some other minor rarer pathologies: small cell carcinoma, carcinoid, leiomyosarcoma, lymphoma, and melanoma. So how do these patients present to us? So always watch out for these common symptoms: hematochezia, which is basically anytime when you have bleeding via rectum, that always needs to be assessed. The most common cause of bleeding is usually hemorrhoids, but this should always be investigated and confirmed. Abdominal pain, constipation, diarrhea, or decrease in the size of stool caliber. Sometimes patients do increase with pain upon defecation, some urgency when having a bowel movement, inadequate emptying, some urinary symptoms, and some pain in the buttock area or perianal area. Then there can be another systemic symptoms in the case of advanced disease, like fevers, night sweats, malaise, appetite, weight loss. So your exam will be done, you will have a thorough exam by your oncologist as well as your surgical people. You will also get some labs done, like complete blood count, LFTs, CEA, which is a tumor marker, any times above 5, that has a negative prognostic value. You'll get multiple procedures done, such as colonoscopies with biopsies, and it's important to get a colonoscopy done because 3 to 5% of patients would have a synchronous primary, so they would have another primary tumor at the same time, but in a different location. Usually the imaging that patients require would be CT chest, abdomen, pelvis, sometimes MRI of pelvis with contrast. Transrectal ultrasound is another common test being ordered if the MRI is not available. PET-CT is routinely not done for rectal cancer unless indicated. And it's important for patients to discuss fertility sparing in patients with childbearing age. Again, no need to go into the weeds of it, but these are some factors that we consider when we are staging colorectal cancers. How far, how deep these things are, the lesions are going inside the rectal wall, essentially. Some things about lymph node involvement, important to know that anytime when you have less than 3, you're N1, 4 or more would give you an N2 status. And M0 typically means that you don't have any distant metastases, and M1 means you have some distant metastases happening. Okay, what are prognostic factors? Of course, the stage that we briefly talked about, the mobility of the tumor. Fixed tumor is the worst prognostic factor rather than mobile tumor. Ulceration, circumferential resection margin, kind of like a fancier term, but basically means how close the tumor is to the mesorectal fascia. Does it invade the lymphovascular spaces? Grade of the tumor, performance status of the patient, response to neoadjuvant treatment, which is chemotherapy, which Dr. Grabowski will talk about, and radiation, which I do. Hemoglobin levels before and during radiation, and preoperative CEA, which is one of the tumor markers. The surgical technique, I won't go into all of those, but basically local excision is used when the tumor is very small, less than 3 centimeters, occupying less than 30% of the rectum, lower grades, greater margins that you can see are free, and no lymphovascular space invasion. And then other surgical techniques would be low anterior resection and abdominal perineal resection. The important thing to know about these two techniques is that the first one is sphincter sparing, and the second one is not sphincter sparing. And this is the second one is usually done for tumors in the lower rectum, and the sphincter sparing is done for tumors in the mid-high rectum. What is TME? It basically goes by the name of total mesorectal excision, and I'll have a slide to show where exactly it is. So when doing a surgery, they take out this area of the rectum, and they make sure that they take out this tissue right here. You can see it by the dotted line as well, because this is where all of those really dangerous lymph nodes are lying around. We call them perirectal lymph nodes, and this is where the tumor likes to go to. Again, I'll be very brief and I'll skim because I know that I might be going over time here. But historically speaking, there were multiple studies that were carried out that showed that after surgery, chemoradiation resulted in better local control and survival. And historically speaking, this became the standard of care for stage 2 to 3 disease. Moving forward, what happened was that neoadjuvant short course radiation followed by surgery was shown to be superior to surgery alone, as well as surgery followed by adjuvant chemoradiation. So the dynamics moved from surgery followed by postoperative chemoradiation to neoadjuvant radiation followed by surgery, or in terms of local control and possible survival. Both of them showed to be superior. But here, this was a slide that I was alluding to, that neoadjuvant chemoradiation appeared to be even better than neoadjuvant radiation in terms of local control, but had some toxicity, which we can reasonably admit to. This was a pioneer or a landmark kind of a trial that happened. It goes by the name of German rectal cancer study that compared neoadjuvant chemoradiation to adjuvant chemoradiation. And what this one showed was that there was superior local control with preoperative chemoradiation, which became the standard of care, and then surgery follows afterwards. The important thing to note was that with this technique, there was an increase in sphincter preservation with preoperative chemoradiation. Then again, people started experimenting with other things. What they found out was it was a short course radiation regimen that turned out to be playing a better role or an equivalent role for at least some tumor stages. So short course radiation without chemotherapy versus chemoradiation with conventional fractionation, or what we call a long course radiation, appear to be equivalent in the preoperative setting. And there are many factors that we consider when we are deciding on one approach versus the other approach. What we call total neoadjuvant therapy, and I'm sure Dr. Grubelski will be talking more about that, would be there were two trials that looked at it, Repeat and Prodigy 23. And what that means is really all of your treatment has been given up front prior to surgery. And this approach tends to be the preferred approach for patients with high-risk rectal cancer, as it reduces distant metastases, improves disease-free survival, and may also improve overall survival. Then this is one of the most recent trials that came out that tried to look at the sequence of therapy and the relationship to non-operative management, which is, again, one of the things that we are going in that direction of not offering surgery to some of the patients and try to avoid any sphincter detriment. The OPRA trial was done that tried to see whether chemoradiation followed by chemo or chemo followed by radiation, which one of them is better. And what this one showed was that chemoradiation prior to chemo may be preferable, especially considering non-operative management, as it results in lower risk of local growth and a higher pathological complete response. Essentially, what that means is that there was a complete response in the tumor, which is a good prognostic sign. So in radiation, what do we do? Like, how does it happen? So once I see the patient, they're going to be simulated in our radiation oncology department, either lying in a supine position or a prone position, typically coming in with a full bladder and empty rectum, having some contrast done, putting on some anal marker, and then acquiring CT slices. We are very fortunate at Lynn Cancer Institute to have some of the state-of-the-art equipment. We have one of the latest TrueBeam models. This is one of that machine. And the other one that we have is VAD-Exact. Again, those two offer us really nice image guidance to proceed forward. RT treatment planning. This is very complicated. you can treat you can see this entire tumor right here. This is a patient lying in the prone position. As you can see, that this is the backbone. These are the femoral heads, and we are treating this area and protecting this area right here. So in short, there's a lot that goes on for every rectal cancer patient. There's a no one size fits all approach that can be used for these treatments. This at LCI, we are very, very fortunate to have many radiation oncologists, medical oncologists, surgeons talking about all of these patients, pathologists, radiologists, and trying to identify these minor factors that may play a role and come up with a unique plan individualized to the patient. And all of these is dependent on accurate risk identification, what the patient can tolerate, where the disease site is, how the patient is presenting, and then we move forward with our state-of-the-art equipment to deliver the treatment. Thank you so much. Sorry for running over time.
Thank you. Thank you for covering a lot of the information, Dr. Saeed. I don't see any questions in the Q&A or in the chat box. So I think that you covered it beautifully. And thank you. I know that you have to leave. So we will now introduce Dr. Stephen Grabowski, medical oncologist. Dr. Grabowski.
Hi, good afternoon, everyone, and welcome. Doing a quick update on some of the newer issues in colorectal cancer. Thank you, Dr. Saeed, for a very informative talk. I will probably not be touching on most of the stuff that she spoke about, but I will quickly address the rectal cancer treatment. So let me just go ahead and okay, here we go. So just cover screening guidelines. So these were recently updated. So we divide patients into average risk for colorectal cancer versus high risk. Average risk patients are those who have no prior history of colorectal cancer or adenomatous polyps, which are the precancer. No family history of colorectal cancer, no history of inflammatory bowel disease such as ulcerative colitis or Crohn's disease, known or suspected history of the hereditary colon cancer syndrome such as the hereditary non-polyposis colorectal cancer or HNPCC or Lynch syndrome, FAP, the familial adenomatous polyposis syndrome, or other rare conditions such as Peutz-Jeghers or the MUTYH-associated polyposis. And no patients that have had prior radiation therapy to the abdominal or pelvic area, which does increase the risk of cancer. So for the patients with average risk colon cancer, which is the vast majority of the population, the screening has been moved forward. It used to be age 50. It's now starting at age 45. And either using a stool-based test or a visual exam of the colon and rectum. So the stool-based tests are the fecal immunohistochemical tests, so the FIT tests, or the guaiac test, which are the old tests where a physician would do a rectal exam and put it on a card and put some a reagent to see if it turned a color. And then more recently, we have the multi-targeted stool DNA test, which you would know as Cologuard, and that one is recommended every 3 years. Alternatively, and what probably has greater sensitivity is a direct visual examination for the colon rectum and a standard colonoscopy, which should be repeated every 10 years if there are no suspicious findings. A CT colonography, which does require the same preparation as a colonoscopy, but they're using CT contrast instead of actually having a scope inserted via the rectum. That is recommended every 5 years, or a flexible sigmoidoscopy, which then should be combined with some of the stool screening tests, and that's every 5 years. Basically, if if you have the high risk category, you start at age 45, or if a family member had colon cancer at a younger age, you count 10 years before that. So if a family relative had a colon cancer at age 50, you should start screening at age 40. And in that situation, you really want to have a more frequent screening. Basically, screening is recommended as long as patients are in good health until age 75. And from age 76 to 85, it can be done according to the patient's preference, as well as whether or not they've had any significant findings previously in screening. And the American Cancer Society does not recommend any screening over the age of 70, assuming over the age of 85. So there is Dr. Said alluded to this before, there is an increasing risk of colon cancer in young adults. There's been about a 90% increase in the incidence of colon cancer in patients between the ages of 20 and 34, and over a doubling of rectal cancer in that same age group. And the reason for this is not totally clear. It's felt to be a combination of things. Lifestyle, eating a lot of ultra processed foods, high fat diets, and some hereditary factors as well. There's a lot of focus now on what's called the gut microbiome. So we have bacteria in our intestines all the time. There are beneficial bacteria and some harmful bacteria. The beneficial bacteria usually rule the day. Sometimes when you take antibiotics, some of those more negative bacteria take hold. That can result in something called Clostridium difficile colitis. So that's a particular bacteria that is in your intestines, but can become more dominant when you remove some of the good bacteria with antibiotic therapy. But it's thought that several of these bacteria in the gut can actually precipitate the formation of dysplastic or abnormal cells, which then can lead into cancer. And they're trying to devise ways to see how they can alter the gut microbiome. So they've actually done some fecal transplants where they've actually taken good bacteria and inserted them into the colon. As you can imagine, that's not exactly the most pleasant procedure, but and they have demonstrated they've been able to change the gut microbiome. But at this point, we don't know whether or not that really translates into any difference in terms of the risk of cancer. But that is an area of very active research. There's also a difference between left-sided and right-sided colon cancers. Dr. Said was focusing more on the left-sided colon cancers, your rectal cancers, but there are some differences. So right-sided colon cancers tend to have a lower incidence, but that incidence seems to be increasing and tends to be more common in females. They tend to present with a higher stage disease, in part because they're further away from the rectum, and so you're less likely to see bleeding, less likely to have pain with bowel movements. So you tend to see larger tumors. You may see more mucinous tumors. It is a common site for a certain type of mutation called MUTYH, which causes increased polyps, and tends to also have certain mutations, including microsatellite instability and BRAF mutations. It has a worse overall survival, even if you adjust for having the same stage of disease. So that even if you take a tumor on the right side versus left side that are exactly the same size, whether they spread to lymph nodes or not, the tumors on the right side of the colon do have a worse prognosis. Left-sided tumors, again, higher incidence overall, but the incidence is decreasing. They tend to present earlier with smaller tumors, and this is more common to see with the Lynch syndrome or the familial adenomatous polyposis, and tend to have better outcomes, better survival. So how does this all happen? So what happens is you have normal cells, and over a course of time, there's loss of a particular gene called the adenomatous polyposis coli gene, and that forms an adenoma. So sometimes you'll get polyps that will be a tubular adenoma, and those are precursors to cancer. So any adenomatous polyp needs to be removed. As it evolves over time, you then get KRAS mutations, which become a late adenoma. They start to get some dysplasia of the cells, so they're becoming more abnormal. And finally, you get loss of TP53, which kind of acts to control the growth of the cells, and it becomes carcinoma. This is why it's critical that polyps be removed, especially adenomatous polyps, before they can become cancer. So, in terms of early stage colon cancer, where cancer hasn't spread, the treatment's pretty standardized and hasn't changed that much recently. The biggest thing that I would say that's changed over the last couple of years is that for patients, so backing up a second, stage 1 colon cancer is just where it's on the inside lining of the colon. It hasn't penetrated through the muscle layer. Stage 2 is where it penetrates through the muscle layer but hasn't spread to the lymph nodes. Stage 3 is spreading to the lymph nodes, and stage 4 is when it spreads to other parts of the body, with the liver and the lungs being the most common places for it to metastasize. So stage 1 colon cancer is treated surgically. Stage 2, again, is usually treated surgically. There are certain high-risk features, such as a patient who presents with a big enough tumor that causes an obstruction, or the tumor actually perforates, or it's stuck to another organ, such as the bladder or another part of the body. Those are considered higher risk stage 2 patients. Stage 3 patients are the ones that have positive lymph nodes, and those are the ones that we usually do recommend adjuvant chemotherapy or chemotherapy after surgery to reduce the risk of recurrence, because the risk of recurrence is much higher in patients that have node positive disease. And the thing that has changed in recent past, I would say 2 years, is there was a compilation of multiple studies that looked at 3 months versus 6 months of chemotherapy. Up until that point, 6 months of chemotherapy was the standard, but the trial, which was called the IDEA trial, compiled a bunch of different trials that were looking at chemotherapy combinations for 3 months versus 6 months. And what they found is that 3 months of a chemotherapy regimen that included an oral chemotherapy drug in combination with an intravenous chemotherapy drug was equivalent to the old standard of 6 months of intravenous chemotherapy. So our thinking has evolved to recommend 3 months of chemotherapy for the majority of patients. Sometimes doing the oral chemotherapy paradoxically actually has more side effects. So sometimes patients will actually prefer doing the 6 months of intravenous chemotherapy. I want to focus now more on when the cancer has spread for stage 4 disease. And this is where we get into some of the more personalized medicine, looking at what type of mutations we can find. Do we have targeted therapies? Does immunotherapy work? And this slide shows us what the targeted mutations are in colon cancer. Vast majority are KRAS mutations, which unfortunately at this point we don't have any targeted therapies for, except for the little sliver at the bottom around 530, KRAS G12C, which is only 3%. We actually have targeted oral drugs called tyrosine kinase inhibitors, or TKIs, which target that particular mutation, that can be combined with cetuximab, which is a monoclonal antibody directed against something called epidermal growth factor receptor. Swinging around to the orange slice, the BRAF V600, which is about 10%. Again, we have a targeted therapy for that, which again combines epidermal growth factor receptor antibody, such as cetuximab, combined with encorafenib, which is a agent that targets MEK, which is downstream from BRAF. But again, another targeted therapy approach. 5% have that at around the 9 o'clock position. You see HER2, which is much more commonly associated with breast cancer, but HER2 is overexpressed in about 5% of colon cancers. And we do use the same drugs that are used, excuse me, the same drugs that are used in breast cancer, Herceptin, and other drugs in that category, which can target that HER2 by binding to the receptor. NTRK, NTRK, which is 1%. We actually have NTRK inhibitors. And then finally, the green one around the 10 o'clock position, MSI-H, which stands for high. So MSI is microsatellite instability. So normally our cells have repair mechanisms that allow it to repair any DNA damage. Sometimes some cancers lose that ability to repair DNA mismatches, which are called MMR, mismatch repair deficiency. And that results in something called microsatellite instability. So if someone has MSI or MSI high tumors, those are the patients that respond to immunotherapy. You may have seen drugs advertised on TV, Keytruda or Opdivo. These are drugs that target something called PD-L1 on the surface of the cancer cells. And we know that in patients that have MSI high tumors, that these immunotherapy drugs have a significant response rate, and occasionally will put patients into complete remission. There was a recent study about a year or so ago reported out of Memorial Sloan Kettering that took a small number of patients with rectal cancer that had MSI high tumors, and instead of treating with chemotherapy and radiation therapy, they actually treated them with immunotherapy, and 100% of the patients achieved a complete response. So it is a very exciting area to investigate, and we continue to look and see, are there ways that we can make the other 95% of colorectal patients more responsive to immunotherapy. But at this point in time, only the MSI high tumors are ones that can respond to immunotherapy. The other major advance in monitoring, both for early stage and metastatic disease, is the use of liquid biopsies. So on the left-hand side, you see looking at what are called circulating tumor cells, which is a technology, but it's a much more difficult technology. You're actually looking for actual tumor cells in the blood. The more common technology is looking for circulating tumor DNA. And what you're looking for is certain mutations in the cancer cells that are expressed in the DNA, and then looking for the tumor DNA in the blood and being able to detect that and determine. So it's useful both in early stage disease because we can determine if someone is at higher risk for recurrence, and monitor them after their initial diagnosis to see if at some point in time it goes from a negative to a positive. And it's also good for monitoring patients that have more advanced stage disease to see if they're responding to therapy. And just to kind of give you an idea of the power of this was a study that was published that showed that in colon cancer patients, those that had a negative circulating tumor DNA had a very, very low risk of recurrence. This was extending out 3 years from the time of their surgery. And for those patients that had positive disease, you can see that the line keeps going down and down and down, that they are at risk for recurrence. We're also using it now for those patients with stage 2 disease, the node-negative patients that where sometimes they're unsure whether we should treat them with chemotherapy or not. And if we do a circulating tumor DNA shortly after surgery within a few weeks, and it comes back positive, then we are recommending chemotherapy in that situation. Although at this point, we still don't know if that is going to change the outcomes. We know that the circulating tumor DNA predicts that they're going to have a worse outcome and they're higher risk of recurrence, but we don't know if treating them in that situation makes a difference. Those studies are ongoing, and probably within the next year or so, we'll have information to confirm or let us know whether we're not doing the right thing by treating patients with chemotherapy. But at this point, off of a study, we're at least discussing with individuals about the possible use of chemotherapy. if you test positive, even if you had no negative disease. The one last thing I'm going to cover is just Dr. Saeed talked a little bit about rectal cancer and our approach. And so originally, when for many years, rectal cancer was treated with surgery first, followed by radiation and chemotherapy. Then there were data that she showed that doing the radiation up front, usually in combination with a low dose of a chemotherapy to sensitize the tumor to radiation, that approach was better than waiting till after surgery to do your treatment. And now we've migrated to what's called total neoadjuvant therapy, or TNT, which shows that by doing both the radiation therapy and full dose chemotherapy prior to surgery, that a proportion of patients will have a complete response. And those patients can be observed and monitored very closely, and sometimes may be able to avoid surgery. And that if they do have a recurrence, that they can be salvaged with surgery at that point. So our approach these days is to treat with radiation and chemotherapy up front for rectal cancer, and then restage at that point with scans and colonoscopy. And if there is no evidence of cancer, to follow patients, giving the patient the option of being followed very closely versus proceeding with surgery. And if they're followed closely, they need to be scoped every 3 months and scans every 3 to 6 months. And if there's any evidence of recurrence, then proceeding with surgery at that point. But it can, in some individuals, avoid the need for permanent colostomy surgery. And with that, I'm going to stop and take any questions.
Thank you, Dr. Robalski. This is such important information for all of us. I had a question. Oh, there's one question in here. I think mine went away. Can you see it in the?
Yeah. So, yes. First of all, your question was, well, you asked about which screen would I recommend for someone with an average risk. I still think colonoscopy is the gold standard. Obviously, if for standard risk, if you don't want to go through the colonoscopy, I guess Cologuard would be my second choice.
Okay.
And so, but I would still say colonoscopy is probably the gold standard. The question was asked if someone had a colon resection, do they still need to have a colonoscopy? Yes. So most of the time when they do a colon resection, they're not removing all of the colon. So you still would need a follow-up colonoscopy. Usually, if someone's had surgery for colon cancer, they have a follow-up colonoscopy 1 year from the 1 year anniversary from their surgery. And then depending on if there's any findings at that point would determine how frequently they would need a colonoscopy. But at that point, the colonoscopy is going to be much more frequent. It might be every 2 years or every 3 years, not waiting 5 or 10 years for a follow-up. So usually a colonoscopy at the 1 year anniversary, and then anything after that. There was another question I saw.
Mm-hmm.
Hold on, I missed it now.
Can you see it? It says, are there long-term effects to chemotherapy? And then she said, love the GI team.
Thank you. So in terms of long-term effects, the only long-term effects, so the standard chemotherapy that's used for colon cancer is, again, this is for patients that are just getting for adjuvant treatment after surgery. I'm not talking about the patients who are on chemotherapy for metastatic disease, but for adjuvant therapy, in terms of long-term effects, the only real long-term effect is one of the chemotherapy drugs that's used both with the 3-month regimen and the 6-month regimen is a drug called oxaliplatin. And that has, as a side effect, development of peripheral neuropathy as a cumulative effect, which that means you get numbness and tingling in your hands and feet. And that sometimes doesn't completely go away after you stop the chemotherapy and can be a long-lasting side effect. Generally, it's less with the 3 months of chemotherapy than the 6 months, which is another reason why the 3-month chemotherapy is more advantageous because you're getting exposed to the oxaliplatin for a shorter period of time. But that is the only real long-term side effect from this particular chemotherapy. Now, with any chemotherapy for any disease, there is always a chance that you can get some damage to the bone marrow, and that many, many years later, you can have a bone marrow disorder, something called myelodysplasia, or even sometimes it can evolve into leukemia. That is extremely, extremely rare with the drugs that are used for colon cancer, but it is a risk with any chemotherapy for any disease.
Any other questions? Yeah, this was very comprehensive, Dr. Grabowski, and we appreciate it. As one of the many people with gut issues, we're listening very intently to everything that you had to say and appreciate
And the most important thing is to get screened. And certainly if you're having any symptoms, really do not ignore them and do not just write off, again, if you have blood on the toilet paper or blood in the stool, not to just write it off as hemorrhoids, but go get checked out and find out that it is hemorrhoids, and then you don't have to worry about it.
Yeah. Yes. Okay. Thank you very much. And
all right. Thank you, everybody.
This presentation was recorded, and Lee will send out an evaluation form, which we really appreciate everyone completing the evaluation and sending it back to her. We've been working on trying to get our presentations posted on our website, and we're still in that kind of process. But if you do want a copy of this to forward to family or friends, or to re-look at it yourself, you can just ask us, and Lee will send you the link to the presentation. And we want to let you know that our next presentation will be on Wednesday, March 27th. It will be our March nutrition lecture entitled Sustainability in Nutrition and Gardening, with Brandy Hyatt, our oncology dietitian. And for anyone that is visiting the Lynn Cancer Institute, or for any of our employees, we do have an educational table in our lobby that's focused on colon cancer this year. And I'm going to send out a notice later, but we're going to kind of recognize colon cancer awareness by having a Wear Blue Day at the Lynn Cancer Institute. That'll be March 20th. And I'll send out the information on that. So thank you to Dr. Grabowski, and we'll thank Dr. Saeed when we see her. And everyone have a great afternoon and a great weekend. Thank you so much.